the sources of funding are multiple. So, but at the community level, there must be a structure. Right now, we don't have those structures.
So, coming back to you again, Dr. Laz, this brings us now to open up the conversation about the main issue that we should focus in talking about, which is domestic resource mobilization, domestic funding. If rural health systems are constantly patched together from different sources, what will it take to build a more stable, domestically driven financing model that communities can actually rely on?
Thank you very much for that. Domestic funding is quite critical because it's the most sustainable financing that we could have. And looking at what point do you define that domestic, national level, state level, local level? I think it's all contributory, but first of all, we need to clearly, define who is responsible for our primary health care.
Mhm.
Uh, in Nigeria, we have a national primary healthcare development agency. We have states, we have, so, and because of this national, a lot of things is being centralized. In my view, I do not think we should, be discussing why I'm using primary healthcare is not because primary healthcare is same as rural care, but generally speaking, over 80% of our healthcare needs can actually be met at primary healthcare level, whether it's rural or urban, if it's fully functional. So it's difficult to discuss rural health without, or any form of health without dwelling a lot on primary healthcare. So having that federal agency that works with the various state agencies, and a lot of things are controlled at that level, a lot of influence because a lot of funding is also and coordination is coming from that level. It's good in one way, but it's also a kind of disruptive. In my view, I think if we could make primary healthcare a state thing,
Mm.
every aspect of it, of course, we could have a department in the Federal Ministry of Health that will be doing more of monitoring and evaluation, doing rankings, supporting the states to ensure that they are aligning with the national health policies and stuff, as it were. But being a very diverse country, one policy cannot work exactly the same way across all the states. And that's why we have states. So let every state kind of design a model, that works best for them, given their cultural peculiarities and also given their environmental issues and all of that. Also given the resources that they have. And speaking to that, financing will come into it. Asset-based community development is a model that, okay, what do we have? Health is expensive everywhere in the world,
That's true.
so, and we now look at the states on how best do we finance this in a sustainable manner. And if it is also seen as a business because it's seen more as charity, and that's treating health as charity in a way. There's a lot of tokenism where that even governments will be operating as if it's an NGO. You want to go and do a medical outreach, take pictures, and do as if you are doing something. No, health is a 247 service, and for any 247 service, it's something that just distraction for a few minutes could be catastrophic, because those few minutes could be a period that you need to respond to a very serious emergency that may come up, and it might be very expensive. So every community should have a health committee. Our National Health Act 2014 created that as part of the health system. Every village should have a health committee, so because health is not just what happens at the facility, there's a community component. So, which is obviously largely neglected: health education and prevention, environmental management, water, sanitation, hygiene, those issues are community level uh, activities, and these communities, especially rural communities, need it more because the language of communication in our media is mostly English language, but you need to go to school to understand it. But when you have these structures at the community level, you know, health messages are passed in the language people understand. Communication is done in the language in a culturally sensitive manner. So with that, community is playing their part, and if they need to mobilize some financial resources to support that, volunteering, community service, that's there's some kind of shared cost that happens when those the community is playing their part. So, and that also creates some kind of linkage because there has to be community to facility linkage. You
Mm.
can do referrals from the community to the facility. You can also do a reverse referral after successful management of a patient back to the community, especially where certain behaviors or where a disease is coming from the environment, where the community needs to ensure that the person don't get another exposure to whatever caused that disease. So the lack of this structure in a lot of or majority of communities, in my view, is a huge gap.
Mm.
So which is also making the financing or the funding of health is creating some kind of gap, and it's also causing inefficiency because the community leadership is also supposed to provide oversight to those at the facility level, also provide support, so there should be a linkage between those in the facility and the community. It's that horizontal linkage where support, resources, and all is required. Then now the vertical relationship that goes from the community to the government, whether it's local or the state, is also supposed to exist so that budgeting will be based on needs. What happens now is at the state level, people just budget based on whatever they think is important to them. Okay, we want to supply one sphygmo manometer to all health facilities. So how many do we have? 790 health facilities in the states, or 1,500 health. Okay, one sphig times 1.5. They just put it that way in the budget and procure this fig and start distributing to everybody. So some health facilities may have this fig and they don't need new one. Maybe what they need is a weighing scale. So I'm just using some very simple
Yeah.
tools and equipment. Or what they need is a bed and mattress, for their patients to use. But you supply the additional sphygmo manometer and they just put it somewhere in the store. And maybe after a while, it might even get missing. So the money has been spent, but it's not addressing any problem.
Mm.
So, but if we have these robust, community structures, the health committees, and they are working together with the health facility, civil servants are often shy to table their needs before their bosses. So the communities can be the one doing the talking. So they can engage their representatives, they can reach the commissioner, they can use their political leaders, and speak to them directly that this is what we need. They can send those lists. So, and if they want to do needs assessment, instead of the state to spend money, hire consultants, deploy them to all the facilities to do this needs assessment, they can just share a template to the various community health committees. A simplified tool that can just say, okay, this is what we have, this is what we don't have.
Exactly.
Turning those, and some people do the analysis within the state monitor and evaluation unit, or the data policy and research DPRS unit. Pull those things together and be able to analyze. Okay, these are the needs, and the state will budget based on that. So because of this, we are not doing like zero budgeting or need-based budgeting. We're just allocating they said, okay, health, we allocate this amount to you. So just go and divide it whichever way you want. And people stay based on their instinct or whatever that is fanciful to them. Oh, let's buy ultrasound for all the general hospitals, and they procure. We don't ask questions. We have a radiographer who can use it in that. So they send these ultrasounds, maybe 15 general hospitals they have. And out of the 15 general hospitals, it's only two that may have a radiographer. The other 13, the ultrasound will be locked up somewhere, so, and not put to use. And these wastes, because there is no much supervision, monitoring, coming from the real users themselves. That's that gap. People just complain when there is a case of negligence. They run to social media and they lament, go back to status quo. But if you have this a structure and ensuring accountability, even at the rural communities themselves, getting that feedback, I believe the resources are not unlimited. We always have more needs than available resources. So, in summary, the sources of funding are multiple. So, but at the community level, there must be a structure. Right now, we don't have those structures. We have at the world level, World Development Committee, because of the Basic Healthcare Provision Fund,
Fund. Yeah.
mandated that there must be a WDC and the chairman has to be a signatory. That's the only reason that WDCs are existing. But beyond signing those checks for those fundings, they are not really performing other responsibilities that they ought to. So, but people, I usually argue that people have more emotional attachment to their communities or villages or districts, as the case may be.
Thank you so much for that explanation, Dr. Laz. I I agree with you on the fact that the way we are doing healthcare generally right now is not sustainable. And I'm also a student of ABCD, and I've seen how impactful that can be when you get communities to be involved in issues that are of an enormous concern to them. And we talk a lot about accountability and setting up accountability to the point that this time around, like oftentimes it now sounds like one of those buzzwords that I've heard over time in the development sector. Because what does accountability really do mean to a community person, a government stakeholder, and other forms of interest group, right? And what comes back to my mind is we've tried different models and they are not working, and we're pivoting, and to the point where we get to this place. How do we now, as a people, really get to tell ourselves the truth as a community? Because I leave half of the blame of sporadic health funding to government, but I leave half to the communities themselves, because it takes two to tango, right? So when we talk about accountability, and we know that communities need to show interest to move government needle. Oftentimes when you see government commit more than they would lackadaisically want to, is because communities are aware and communities are asking the right question. But I understand there are issues that have to do with, skilled engagement as well, because you need to know how to structure what to ask before you actually ask this question that makes sense. Otherwise, you're just, complaining. And government don't budget with complaints. So when we talk about this accountability, how do we get communities themselves to organically engage with government to the point where we are moving this needle, irrespective of the structure, whether the new model you've spoken about, which I love so much, bring government more closer to the people rather than being at an abstract level where communities don't really know how to engage. So they just feel like this is not our thing. Bringing them closer to government or reintegrating community upward in ways that their voice goes up. How do we make that accountability really work for everybody to be engaged to get us to this model that you are talking about?
If you're enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. Please leave a comment, share, and most importantly, give us a review. It helps others discover this important conversation.
The way to make this work, in my view, is for the state to take this more serious. I would like the primary healthcare development agencies to have a strong community health department that will set up a template that will, issue a memo working through the Ministry of Local Government, and Chieftaincy Affairs, directing communities to set up health committees. We already have policy framework for that. The World Health Systems Policy, has already defined what the composition should be and what their responsibilities are. So every state should now redefine it based on what is most applicable to them and what is most feasible. Even within the states, because many of the states are also not homogeneous. The different districts will also adapt what is most applicable to them. But every community, at every governance level at community, whether it's the Emirates system or up to district level in the northern part, or the autonomous community within the eastern parts or the western parts, the upper level, so whatever level a community is defined, even up to the level of campus communities, and there is some incentive. Okay, the community with the best performance this year, the government will make additional investment of, or some kind of recognition, or even plaque, and they are celebrated, and there is, some additional stuff that goes there also. Okay, your health is okay. If you do this, tell us what to do for you. That is what maybe 10 million or 100 million, as the case may be. So there'll be healthy competition, so because it's being tracked. So that for me is the missing link. Number one is the government should require, there's already a policy, but there should be a requirement, a directive. And when that directive goes, every community will obey. But if you leave it to people should know the right thing to do, the attitude to health generally is more of reactive than being proactive, unfortunately. So people are more likely to, people are dying, what do we do? They start responding. But when everybody is healthy and you're talking about health, they feel it doesn't concern them. They will say, talk to the doctors, talk to the nurses, it's their business. So that community action has been demonstrated in security matters, is also demonstrated somehow. The PTA in the education sector, Parents Teachers Association, exists in almost every school. So that's some kind of community, because the parents are in the community.
Yeah.
Community and school kind of arrangement. And you have, when the school doesn't have enough teachers, the PTA, they contribute monies and hire those they call PTA teachers. because they want their children to get some good education. So, but health is the place we don't have like people's health workers kind of arrangement,
Mm.
So everybody is just on their own, and only when they get sick before they care about what happens. So we could bridge that gap through the health committees, and the government should make it a requirement.
Yeah, thank you. Thank you so much. And as you were talking, one thing that I was wondering about is how come a country like Nigeria, with roughly 45 to 50% of its population living in rural area, that is over 100 million people, still treat rural and primary healthcare as a cost center rather than strategic investment site. And while you were explaining all of these things, I'm just seeing this to be a clear investment model that a government can use with inbuilt incentives to continue making this work. But because we don't care that much to go foundationally to put in the actual structure that is needed, I think sometimes we like celebratory models like, oh, we have basic healthcare provision fund, national level, and then we launch it. The minister comes to say, the president comes to say something, everybody wear agbada, and we are done. What is the actual implication of domesticating that model to the grassroots is what people get lost in transmission. Nobody just understand. As long as we have done flamboyant thing in one big hotel and decorate and have decorators do things and people wear the agbada and blow grammar like me, we are okay. But as you were talking, I remember when we were doing accountability work with Mama Ye, I was a comms person, so I was supporting state produce the scorecard, for RMNCH, right? We had Lagos, we had Bauchi, we had Gombe State, we had Kano and Kaduna states. I think about 6 states that we had that we're supporting with all this process. Now, and this is where I'm going with political will, because I don't want to ask you the political will question. It's obvious. The Lagos State governor, as at that time, was very interested in ensuring that they push health forward. They were even far more leading the technical work than we that were supporting the state. Everything would come to say the government will be like, okay, we look through this. How do we domesticate it within the health infrastructure? We know you are, a donor-driven organization, that when you leave, we would not be suffering and be lacking expertise. What we actually need you to do is tell us how to do this thing and not show us, because when you are showing us, we don't know how to do it. By the time we left, now I know that evidence from Mama Ye has wrapped up maybe like 2 years ago. The Lagos State government still run all of those accountability processes that were included. And they've gone far beyond what we even started. I still see it. And that's the benefit of self-driven political will of state actors who know what they're supposed to do. Because sometimes we can talk about model and they look very beautiful. Theoretically, they are fine. But the implication is the most important thing, because we can take primary healthcare provision fund, we can take the PHC under one roof as it is right now, and the state looks at it and say, we are going to domesticate this properly and make it work, right? And you see things working. But my next question is, why is it that all of these policies are very beautiful on paper, yet, there is always this lag around what a state is committing itself? And now, a state, because rural health is really down to the people, right? It's now to the state. Why do some states, draw back or stay back in making sure that they look at all of these things and have the ability to domesticate to the level where it works for them? And I know you run the Make Our Hospital Work campaign across board. And thank you for starting that initiative. So what have you learned that is making states do all of these things?
Well, thank you very much. You touched on it already. It's a political will, number one. In some cases, it's also our behavior towards health generally. I usually make reference to this study the NOI polls did around 2015 elections, asking people the top things that matters to them most in that election cycle, and health was not in the top five. So of those that responded to that poll. So if a national poll was done and health doesn't come in the top five among the citizens, then you don't entirely blame the leadership because
Yeah.
the people push more about what they want. People don't often ask questions or make demands, to the and when you are in governance position, so many things need attention, push and pull all over the place. And the ones that tend to push more, probably tend to get more,
More
you
attention.
know. And the leadership is also coming from the followers from the same environment where people see health more from charity. I
Mm-hmm.
don't know if it's because orthodox medicine, health, the nature it came in our environment, through the colonial folks and through the missionaries coming,
Mm.
setting up, hospitals. We have our own kind of healthcare, but it's not designed exactly the same way with the European style. So that style coming to displace our own traditional
Traditional.
form of care, and the way it came just that way, and from there the government now took over from the missionaries, and a lot of things were done free of charge, and it kind of formed this mindset of it has to be is a free service. So even the government sees rural health more from the outreach perspective. Go there, gather people, do outreach, just check spontaneous thing, and everybody is happy.
Mm.
So and also the way the people who administer or who manage the health sector is also contributory. As physicians, we are primarily trained on individual patient diagnosis. So a patient comes with a health condition, you ask some questions, do physical examination, run some investigations, and you make a diagnosis and you treat. Most of our trainings are around that. Of course, we do community medicine that expose us to some of these population health stuff. But the training we get in undergraduate, medicine, coming out as a medical doctor, is not entirely sufficient to run population health.
Mm.
So, is that perhaps the master's level, you do a master of public health, or even some people who don't necessarily do masters, but they do some kind of population health interventions, and they gain certain skills that is relevant in managing population health. So that is crucial. But a lot of persons who we appoint as commissioners for health and even sometimes minister of health don't have experience in managing population health.
Mm.
So their orientation for health is just about hospital, sickness, and treatment. So
Mm.
most of the policies they pay attention to is just on diseases, diagnosis, and treatment, and just have hospital-oriented kind of attention. And the population health that does a whole lot of primary health care, and primary health care has community and facility components. So whether it's a behavioral issues that you want to change, it
Mm-hmm.
requires behavioral change communication, community mobilization, and it takes time for the message to sink. Whether it's the environment, the One Health approach, man, animals, and the environment,
Mm.
sanitation issues, it's also community level interventions. Have access to good quality water,
Mm.
open defecation, ensuring that is eliminated. These are community level interventions that
Intervention.
have critical impact. on health, or even access to the healthcare financing, health insurance. You have those who are employer provided, but you also have the vulnerable persons who are unable to pay out of pocket. Those who are extremely poor that they can't afford to pay premium, children under 5 years, students, elderly people, persons living with disability, people who don't have jobs, who is paying for them? And the those who are in the informal sector who are making money, but not in a very organized distance. So how do you get them? They are
into the
making,
system.
they are getting some income. How do you get them to organize themselves and be able to buy health insurance as well? Involving them from the planning stage, because a lot of times you come and we just make policies and impose on the people. They don't even understand the rationale. They don't, and we start accusing them that, oh, this is for your own good. You are not cooperating. You are sabotaging government. No, there are processes to doing this. You don't just stay in the room, make certain policy and come and impose on the people. So a lot of people who run health or who manage population health in our states do not have these skills and experience of community engagement. And
Mm-hmm.
a lot of times, even when they come with good policies, it does not succeed. The people can't connect to it. So that's also part of the challenge in those who manage. So even where you have political will, where you have good policies, where you even have some good funding to getting certain things done, we don't get the right people who will translate those good plans to actions, to practices, and to successful implementation that will be sustainable. It cannot be sustainable when the people don't understand it or
Yeah.
understand the rationale, or they don't buy into it. And with that, the government has political capital. It makes them popular. The people
Mm-hmm.
will hail the government. The government will be happy, feel that they are doing the right thing, and the people are also cooperating. So a 360 thing. So it's some kind of different interplay. So Lagos is a cosmopolitan state.
Mm-hmm.
The rural part of Lagos is most likely floating in the water. The slums. It
Yeah.
has a highly educated population. A lot of people can understand English, whether they go to school or not. You can learn
Mm-hmm.
it on the street.
Thank you so much for explaining all of this. So let's take a quick break. When we come, we draw down and wrap up.
Do you want to help drive rural health forward? We're looking for passionate volunteers to support our work, from research to storytelling to business outreaches. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up.
Welcome back. So, Dr. Laz, as we wrap up to close, and I usually like to leave on a good note. If Nigeria becomes serious, because I don't know whether we are becoming or we are at that stage right now, but if Nigeria becomes serious about strengthening domestic resource mobilization for rural health, say over the next 5 years, where do you think that the biggest shift needs to happen first? Is it in regards to reform or fiscal decentralization or changing leadership mindset or having, you have established stronger community engagement, but what would you say, let's focus first and do?
Yes, I would start with strengthening community governance of healthcare, more community involvement. That's for me is the biggest gap, and no matter the amount of resources we throw into health, there are responsibilities from communities, especially rural communities where there are more need and there are less options. So that community involvement is key to a lot of things working. So it will help to increase investments
Mm-hmm.
in the health sector, because individuals can invest their time, people can invest their resources, and as the case may be, and accountability on both sides. The health workers accountable, the community will hold the health workers accountable, and also hold the government accountable as well. So that for me is the way to go. All the while we have this conversation without really having the people from demand side on the table. We make decisions based on what we think is best for them, and when we go to implement, we might see something else. And a lot of times, we also don't use data for decision making.
Yeah.
So involve the community, use data for decision making. Policies we have some of the finance policies, when it comes to that. We're always good in making those policies, So it's translating those policies to action,
Thank you so
community
much.
involvement, and use of data for decision making, and putting our resources based on need. That's also part of using data in making those decisions. That's for me is the way to go at this moment.
I like that. I like that. Thank you so much. And for me, my own takeaway from this conversation is that it's ultimately a question of country priority, right? And leadership, and whose well-being we want to prioritize, actually, because if we want to prioritize the well-being of community people in a country where nearly half of those population live in rural area, I think that requires a deliberate plan to invest in community participation, stronger accountability, but also not seeing health generally all the time as a charity, but as an investment opportunity where government itself can begin that and then draw in other investors in ways that makes things very sustainable. But before we sign out and let you go, Dr. Laz, because this conversation, even though we use Nigeria to set up as a case study, other countries also do struggle with their rural health system. And I wanted to ask you if there's one lesson from Nigeria that you think other countries struggling with the same rural health financing issue should pay attention to, what would that be?
Yeah, that's a good question. I think there is also strong lesson in community involvement as well. Even though we consider it as a gap, but generally speaking, every aspect of health, but it's also worked in certain areas. Recall that around 2008, 9, 10, there was a whole lot of vaccine hesitancy in some parts of Nigeria. So, and that's the world's capital of polio then was in Nigeria. And within a decade, between 2010 2020, the country was certified polio free. A whole lot of effort went into that, but very importantly was involvement of traditional leaders and religious leaders. So that was responsible for the shift. And when they now started adding their voices, when they started talking to their people in the language, and these are people they could trust. So some of those misinformation related to vaccines, were substantially reduced, because people could now see those they relate with, people like them, vaccinating children themselves, sharing on TV, and this community mobilization. It worked. That's for me is something that people who are having any form of challenge, or countries, could also deploy health education and promotion driven by communities. Always or most often get to work.
That's a fantastic response. Thank you so much, Dr. Laz, for joining me today. I really appreciate how you have helped unpack all of this domestic conversation beyond policy language, but most importantly, what it means for rural communities to actually be active participants in designing the health that work for them. I'm truly grateful for the work that you continue to do. I want to say this. I think I started off with saying that, and I want to reiterate that I'm grateful for the work that you continue to do. It's not easy every day when the whole country is on the move, that experts like you would stay and go like really closer to the community to continue to provide care and services. So thank you very much for that. To everyone listening, thank you for joining us on today's episode of What About Rural Health. If today's episode moved you, challenged you, or made you think a little bit differently, please follow, subscribe, and leave us a review on your favorite podcast platform. And as always, let us continue to ask the question, what about rural health? Until next time, I'm still your host, Chinasa Imo. Bye for now.